Small disclosure, this online seminar is being recorded for future educational purposes. Join me in a short history lesson on the National Association of Community Health Workers. We are a young organization with 3 years in operation. NACHW has a strong and diverse individuals that sit on its boards of directors, whose primary job it is to put shareholders' needs before their own and uphold the integrity and values of the organization. In addition to that, NACHW has 10 incredible staff members across geography who are committed to the growth and evolution that lead our day-to-day operations. NACHW prides itself on strategically developing and advancing the CHW profession. We are a values-based organization, meaning we bring our values to the forefront of everything we do. These include being a national voice for CHWs under all umbrella terms, enhancing policy, advancing the workforce, and driving CHW leadership while building capacity. We proudly hold membership and representation in all 50 states with over 2,000 members in total. I welcome you to the Advance CHW project, which is funded by Johnson & Johnson, and whose mission it is to combat racial inequities and health disparities for people of color. Over the last 2 years of this program, Johnson & Johnson leaders have worked tirelessly to develop a national survey that explores and builds recognition of the CHW professional identity. Community health workers' integration within medical, public health, and social service initiatives is essential to eradicate racial and social injustice and health inequities experienced by minorities. This data should be used for action to reverse harmful practices and barriers to CHW self-determination, leadership advancement, and sustainability. Before we start our journey into data learning, I would like to pass the mic over to Allison Joslin to share the survey history and methodology used in analyzing this data.
Thanks, Michaela. We share this next slide to highlight key learnings from exploring the data, as well as how we processed or cleaned the data to ensure data quality. And many of the questions we asked for CHWs to reflect on experiences during the year in the midst of the COVID-19 pandemic and civil unrest. This enormous undertaking is in building a state-of-the-art 51-question survey by CHWs for CHWs during this unprecedented time was organized by NACHW with CHW leaders and other stakeholders at the helm. On the left side of on the screen, the data team identified missing responses, explored neutral response meetings, removed duplication of entries, and notated any unique characteristics during the data cleaning process. For example, 28% of CHW respondents were from North Carolina because due to a single employer distributing the survey to their team. We also disaggregated all 51 questions by race and ethnicity, and then also disaggregated the data by national regions. So we explore what disaggregating data means. Disaggregating data means breaking information into smaller pieces to showcase trends and patterns that may not be visible at a whole population. And why would we want to disaggregate the data? It is critical to be able to monitor and describe critical racial disparities and health inequities by location across where we live, work, play, pray, get educated, and get our health care. This allows for further examination from a baseline of data to dismantle structural inequities and further prioritize CHW values. Where we see observable and unique differences, as well as where we are unified and united in responses, we report them in this presentation and certainly in the upcoming release of the report. We also explore the neutral responses, which will give a way of reasons in later slides. On the right side or on the screen as well below, actually above, we want to express that 867 CHWs from 859 different zip codes responded to the survey between the months of June and September 21. 772 CHW respondents in the English version and 95 CHWs responded in Spanish version with 27 different languages spoken. We know that CHW is an umbrella term, and therefore we found that 93 different titles were also represented among respondents and further solidifying the strength and power of this data. So thank you again for reviewing the methodology. I'll hand the mic back over to Michaela for her introduction of our profound CHW leaders.
Thank you for that important background, Allison. Now it is my honor to introduce our amazing facilitators for today. Ms. Lucia Colindres, Chief Program Officer at Ibrero American Action League, Inc. Ms. Lucy Nguyen, Program Manager of the Austin Asian Community Health Initiative. Mr. Gary Ringer, Director of Community and Economic Development at Joy Southfield CDC. And Ms. Maria Ortiz, Executive Director of Familias Triunfadoras in El Paso, Texas. Thank you. Please take it away, Gary.
Thank you, Michaela. Good afternoon, folks. We're taking you along on a journey of community health work. We hope that you listen up to the expressions of CHWs just like you and me. Please take a moment and envision the faces of this data, beginning with the diversity of community health workers by geography, ethnicity, race, and culture. Together, we will be learning who responded to the survey and where they came from as we walk through the social features of the CHW workforce. Follow me to the map on the left. We see that the states highlighted with a darker shade of purple mean there is a higher number of CHW representations, whereas the lighter shades of purple mean there is a smaller percentage of CHW representatives who completed the survey. Now, move your eyes to the right of the slide to the colorful globe. It shows us the percentage of CHWs completing the survey in each region of the United States. We see that each region of the US has an even distribution of CHW survey respondents. There were 3 times more survey takers from North Carolina, which increases the percentage in the South Atlantic region.
We'll give Gary just a minute and I will go ahead and read through our demographics for us. Now move your eyes to the right of the slide to the colorful globe. It shows us the percentage of CHWs completing the survey in each region of the United States. We see that each region of the US has an even distribution of CHW survey respondents. There were 3 times more survey takers from North Carolina, which increases the percentage in the South Atlantic region. We have a question for you. What region is your state a part of? What other states neighbor yours in the region block? So for me, I'm in New Mexico, so my region is mountain, and a couple of neighboring states for me is Arizona and Colorado. Awesome. I see those regions coming in the chat. Thank you. All right, next. We can picture how extremely diverse our workforce is, including 7 primary racial identities, over 28% of multiracial participants, and 37.7% were Hispanic or Latino origin. We gave survey respondents the opportunity to write in and self-identify race, ethnicity, and culture, and 11% of CHWs reported multiracial identities. We can further see the faces of our workforce in the graphics on the left. It is a heavily driven female staff, showing us that 88.6% are female. Only 11% are male. I'm going to call to action right here in the middle for all guys to step up and help recruit more men to the workforce. We know you're out there and doing the work. We can listen and hear our voices through the icon to the right, showing us the languages that we provide services in, which are Spanish, Haitian Creole, and even more native dialects and languages. Now here, we can see our ages, with an equal majority appearing in all age categories, but slightly the highest in percentage is the range of 45 to 54-year-olds, followed closely by 55 to 64-year-olds. And we can also understand the education levels we have completed by looking at the graduation cap to the right. It shows that most of us have some college or even a 2-year degree. Now, I will turn our attention over to our Member and Partner Engagement Associate, Ms. Aurora, to challenge us in opportunities for action.
Thank you, Michaela. And thank you to the almost 150 folks on the call today. It's so great to have such an active audience. So what have we learned from this data is that we really want to focus on recruiting and hiring authentic CHWs who are trusted, have life experience, culture, and language with the communities that they serve. And we want to be educating and changing policies to remove barriers to recruitment, training, certification, and employment, like educational requirements, past criminal record, and English proficiency requirements. And we want to prioritize racial, health equity, inclusion, diversity, and a trauma-informed approach. And we want increased recruitment for CHWs who identify as male and those of non-conforming genders. And we want to permanently fund CHWs' roles in a way that addresses the social determinants of health, policy advocacy, and research payers and funders, that they should recognize CHWs as assets through sustainable financing. We want to integrate and compensate CHWs for language proficiency and life experience skills that they apply to their direct service. And lastly, we want to invest in CHW career advancement pathways like certification and continuing education, tuition reimbursement, pay raises for educational attainment, and scholarships. Now I will pass it on to Lucia to continue us on our journey.
Well said, Aurora. Muy bien dicho. Hello, everyone. Good afternoon. Good morning, where if you are somewhere where it's morning, I don't know. As we move through our journey of community health work, we have reached a very important marker in our walk and our role in networks or associations. As you know, the vision of the National Association of Community Health Workers is centered on unification, so being together, united. Our organization is strong when we are connected with individual CHWs from across the country like we are today, and those who are creating vibrant local or state level organizations. Those are extremely important. We often refer to these organizations as being community-based, CHW-led, or CHW networks and or associations. On the left side of the slide, you see that 41% of the CHWs in our survey are a part of their CHW associations, and the 45%, almost half of our survey takers, are part of a community-based organization led by a CHW. You can also see in the middle bar, 28% of our survey takers are members of NACHW, which is great. Excuse me. This is important because it shows us that NACHW has the ability to reach out to CHWs beyond our individual membership. Now, we want to hear from you. And we want to know what associations or local or national are you a part of? It could be a network, association. Let us know in the chat, please. So as we move forward and as you continue to enter that, I see some already, which some names I'm not familiar with, but those are important, right? Because it might be that we still need to connect the dots, and that's really important. So in this slide, we want to look more closely at the relationship that we have with our local or state CHW networks, associations, or coalitions. The bar at the very top of the slide shows again that 45% of our survey takers are members of these organizations, and 32% of our survey takers are employees. This is encouraging because it affirms that some of these organizations are receiving funds to hire staff that are CHWs. However, the purple bars in the lower half of the slide, where we asked about CHW leadership roles in these organizations, we see opportunities for growth and development. Only 7% of our survey takers are board members, and only 3% serve on a committee. Only 5% are paid for their leadership roles, and 4% are not paid at all for their leadership. Creating space for the leadership that CHWs already possess and building capacity so that CHWs can become future leaders should be essential components of organizational development. And I can share with you that in Rochester, New York, our association, our board of directors is 100% community health workers, and that's written on our bylaws on purpose. We still have support from other individuals. However, who makes decisions for our organization is us. So we have seen in the previous slide, the CHWs have many different roles in their local or state CHW networks, associations, or coalitions. This slide explores the various pathways in obtaining a role in a CHW network. We see that well over 50% of our survey takers obtain this role through their employer, while 21% of our survey takers were connected to this organization through another CHW. 12% of survey takers learned about the network on their own. This is the self-referral category in our slide, and 12% were recruited from another non-CHW. 5% of our survey takers, over 43 CHWs, are founders of the network or associations. We want to celebrate that success and celebrate the CHW founders, and let's create additional opportunities for us to connect to other CHWs to these valuable associations, networks, and alliances. So this next slide shares the top 6 statements that CHWs believe are true to describe their network, associations, coalitions, or alliance organizations. We see that 35% of our survey takers say that their network provides work-related training or certification. 34% of the networks have CHWs in the majority of their membership. And 28% of our survey takers said that their network membership does not have a cost, while 20% say that there is no cost for membership in their network. And finally, 22% of our survey takers say that their network is participating in CHW policy and advocacy. would like to hear from you. I'll share on our end in our network. We do a lot of advocacy, but not necessarily policy. Can you share on the chat, please, what some of your networks have been doing regarding policy and advocacy, or one or the other? Great, I see some notes there. And as we continue to go through the slides, feel free to continue to type. This is really important information for us, because that way we can get to see what some of the priorities are for the networks. I think also that organizing, right? So when you first start to organize, you focus on just coming together. But then as you evolve, for example, for us, we've been in existence for over 20 years. Now we're more advanced and more strategic about how to move forward. And so next steps will be policy for us. Great, thank you for sharing that. That's very important information. So on this slide, we also ask CHWs to identify the top 3 types of supports that should be provided to the CHW organizations. Almost 60%, or 2/3 of our CHW survey takers, said that leadership development should be provided to their CHW networks, and 49%, or almost half of CHWs, said that their networks should receive support for communication about the CHW profession and role. And 37% of our CHW survey takers said that their CHW networks should receive support in program and/or service funding. We have another question that we want to ask you. Please let us know in the chat what type of support should be provided to all CHW networks. This gives us another opportunity to continue to collect more information directly from you if you did not participate in that survey. So please share. Now, I'll hand it over to Aurora to get into action.
Thank you, Lucia. And for this section on networks, some of our opportunities for action is to establish private and public partnerships, focus on innovations across networks that are rooted in cultural and linguistic appropriate CHW local models, and to strengthen education and training materials and lean on CHW network and associations as a trusted resource, provide scholarships for CHWs who graduate in programs to become a local member of a CHW association, and that CHWs should be in a leadership position for every association or network, and that self-determination and viability are lifted up. And networks can model from NACHW with 2 to 3 year terms, significant expertise to transfer, and that these organizations are paid and that are sensitive to diversity, equity, inclusion of roles, and term limits. And we want to develop a career pipeline for future leaders by transitioning volunteers into paid roles and then to leadership positions. And most of all, we want to fund CHW networks, associations, and coalitions, and to do pragmatic leadership activities and co-leadership. And we want to fund programs and campaigns to promote awareness of CHW professional identity, regardless of work or employment title, which could help to unify the profession at the state level and drive increased membership to these organizations. And we want to integrate broad roles that describe the CHW profession in state health departments and other organizations. Now I am going to hand it over to Lucy to talk about addressing racial equity within our data.
Absolutely, Aurora, thank you. So let's explore the next step in our community health work journey by stepping into a discussion on addressing racial equity. Each of the questions we explore in this section reflects the degree to which we as CHWs agree with the questions. We want to note that in most of the questions that were asked in this section, a quarter of CHWs reported neutral in their response. We're exploring that neutral could be based on a few reasons. One, CHWs are not properly equipped on the value of CHW profession with non-CHWs. Two, the determination of writing of roles and responsibilities about CHWs from clinical or professionals that are not authentic to CHWs. And three, there could have been a possible fear or uncertainty when responding to the questions. In this first slide, we asked CHWs about how much they agree or disagree in having authority to identify and address issues of systemic racism and or discrimination. We see here that 29% of survey takers strongly agree. We see that 27 agree, while 9% of survey takers strongly disagree and another 9% disagree. Noticeably, you see that 26% of CHWs were neutral in this question. So how about y'all let us know how y'all feel? Do you feel that you have authority in identifying and addressing issues of systemic racism and discrimination at your organization? Why or why not? While I'll answer in the chat, we'll go to the next slide. So remember when in the beginning we identified our regions in the demographic section. You'll see those regions here again. When we compared responses of disagree and strongly disagree by region for the question, I have authority to identify and address issues of systemic racism and or discrimination, we discovered that more CHWs in the East, North, Central, Mountain, West, South, Central, and New England regions strongly disagree or disagree as compared to CHWs in the South Atlantic, Pacific, West, North, Central, Mid-Atlantic, and East, South, Central regions. So if you were in those regions that might have strongly disagreed, if you want to chat why, that might be the case in the chat. In this slide, we wanted to get a sense of how comfortable CHWs are when discussing racial or health equity at work. So we asked survey respondents to describe a scale of strongly agree to strongly disagree. We see here that a strong majority of us responded that we do strongly agree or agree, so it's about 72%. But 11% of us determined that we strongly disagree or disagree, and then 17% of us selected neutral. When comparing that same question by region for folks who agree or strongly agree, then the question is, I am comfortable discussing racial and health equity where I work. We discovered that more CHWs in the South Atlantic, Pacific, West, South, Central, New England, East, South, Central agree more in comparison to CHWs that are in the East, North, Central, Mountain, Mid-Atlantic, West, North, Central, and East, South, Central regions. Ooh, that's a lot of regions. So when we compared that same question by race and ethnicity, and the question is, I am comfortable discussing racial and health equity where I work, more CHWs whom identify as white, Black, African American, Latin American, Asians or South Asian, and then multiracial agree or strongly agree more so in comparison to CHWs whom identify as either Native American or American Indian and Pacific Islander. So we'd like to hear from y'all. Are you comfortable discussing racial and health equity where you work? Please let us know in the chat. I know for myself, I work at the Austin Asian Community Health Initiative, or ACHI, and we address a lot of health equity and access for Asian immigrant communities. And so I know for us, we're very comfortable talking about racial health equity for our communities. And it looks like most of us are comfortable, so that's really great to hear. So what about how supported we feel in challenging health equities? With that, we are able to describe on a scale of agreement our experience with receiving support to challenge health equities. And we find within our communities, overall, 36% of us strongly agree. 31% agree, while 11% of us strongly disagree or disagree. We also see that 22% of us responded neutrally to this question. So do you feel supported when challenging health equities at work? Let us know why or why not in the chat. Oh, we have a neutral. I'd love to hear why or why not. Someone said sometimes heard, but no follow through. So it sounds like for a lot of us, we feel comfortable talking about health equities, but don't feel that we're supported in the work that we're doing to address those health inequities. Thanks, everyone.
Thank you, Lucy. For this section, for some opportunities for actions that we have identified is to unify CHWs to educate people about what systemic racism and anti-racism is in plain language, and address and educate about tactics to address racism. This can be done through providing culturally competent and accessible trainings on anti-racism. Train CHWs in social determinants of health, terminology, and address systemic racism. We know what systemic racism through experience and feel it physically and emotionally, but we may not know the terminology. And we want to create opportunities for CHWs to lead in creating trust in health systems. And we want to integrate CHW leadership to support evaluation and accountability of healthcare systems and institutions for historical abuses in communities and such. And we want to reimagine policy, build CHW career pipelines with Black, Indigenous, and other people of color. And we want to lead with CHW stories and data connecting lived experience with health disparities and self-determination. And organizations should continually ask, how is racism operating here? And policy, practice, and in processes to establish routine operations in organizations committed to promoting racial justice. I also want to give a plug that I saw some people in the chat talking about the American Public Health Association CHW section. Yes, that is a tremendous organization that exists, and they are doing really fantastic work in the area of educating and bringing CHWs together around anti-racism. And I know Angie put some things in the chat on if you're interested in getting connected to the APHA CHW section and those trainings, we are happy to do that as well. And now I believe we are going to move into our question and answer section. Michaela, if it's all right, we had one from the chat earlier. I was going to go ahead and share with you. Someone asked, how were the surveys distributed, or how did you find or get the surveys to community health workers?
Yeah, that's a great question. I think I can help with that. So from my experience, we used our membership to disseminate the survey, and then our, what was there, 9 leaders at the time? 9 of us also disseminated it to our personal circles in the communities.
Michaela, I just wanted to share, this is Lucia, that there was a lot of, there was a long process for the collection of the surveys, and the outreach efforts were targeted towards anyone basically who was connected and had, you know, followed under that scope of the CHW, without, you know, some individuals had the title or not, but I think it was also the time frame was quite long to ensure that we had good representation.
Yes, absolutely. You're right about that. All right. Are there any other questions? It's hard for me to keep up with the chat. Or come off the mic. Let's hear your voice.
Hey, Michaela, I also just added in the chat that we did a lot of outreach with networks and associations during June and September 2021 as well for our outreach as well.
Thank you for answering.
Aloha, Michaela, this is Auntie Jessie.
Hi, Auntie Jessie.
I just wanted to know 2 questions. We're all 50 states involved in this, and also in terms of the age groups, was there any particular age groups that was reflected in the survey that participated?
Yeah, Allison, do you want to help us with the analyzation?
Sorry, I came on late, that's why.
That's okay. I'm actually going to skip through to where some of your questions are. Yes, we had all 50 CHWs represented in all states, which is amazing, as well as in some other territories. The range, kind of varied between states. We also, your second question was age groups. And yes, a lot of our respondents or CHW respondents, I'm saying our, but a lot of the CHW respondents were of older population, older groups. So we know that we can do a lot more outreach probably with younger CHWs. I hope that answered your question. Thank you, Auntie Jessie.
Yes, it did. Thank you so much.
I can help with this last question in the chat. Yes, these will be recorded and uploaded to our YouTube channel. Were school-based CHW programs included? So we didn't necessarily ask where people worked, but more about the quality of their work. Yeah, Lucia said we need to get these new generations going. Some of us are getting ready to retire.
Michaela, Auntie Jessie again, one more question, please.
Yes.
I just wanted to know how many community health workers associations do we have
represented in the survey?
Yeah.
Or,
yeah.
Allison, can you help with the analyzation?
Yeah, I can definitely get back to you, Auntie Jessie, about how many networks were, is your question how many we reached out? How many networks did we reach out? Or how many are represented in the survey? So wait, represented in a survey, we did not ask a specific question of which association or network are you part of? So it was a general question of, are you a member of CHW network or association? So I don't think, I hope that answers your question, but I can definitely follow up with you, Jessie, for, am I answering your question?
Yeah.
And our questions too, all the questions that we receive in the chat, and if we were not able to get to them, we also creating a frequently asked question sheet so that we have, prepared that as supporting. So our CHW, CHW respondents are not I'm just going to leave it there. So our CHWs responded to answering question, are you a member of CHW network, but not identifying which network we're a part of.
Thank you.
Yeah, Carol, I see your hand up.
Yeah, one of the things that really concerns me with the data around the associations and networks is that only 34% were community health worker majority, which I'm assuming is 51%. which means that 66% of those agencies, networks, associations listed do not have a majority of community health workers. And I'm wondering if that's something that NACHW has noticed, and if there's something that we can do to advocate and change that.
That's a great point. I've had experiences of this data in real life. And so NACHW has definitely noticed, and it is part of our opportunities for action.
Thank you.
Mm-hmm. And then I know I missed a couple in the chat. I'm glad you guys found the YouTube channel. Peter's sending the link to everyone right there. Katina says, I'm wondering how many of you in this call in CHW member-led associations are offering leadership development programs and trainings? If so, have you developed your own programs? Lucia, you want to help with that one?
Yes, I was typing away the answer. And to go back to the other statement that was made regarding the membership. So I can tell you that so we have an association in Rochester, New York. We've been in existence for over 20 years and all that. That's the one that I was saying, our board is 100% community health workers. However, our membership is diverse. So the question that was asked, we have allies and we have CHW that are members, because in addition, we have supervisors that can be members. It's just when we're specifically targeting certain activities, we do have that separate, our membership separated by allies versus the community health workers. And then going back to the other question about the leadership training, a couple of the things that we have done internally has to do with finance management, because that's a big one, right? So if you become a non-for-profit, how do you manage budgets? Strategic planning is another one. Grant writing, it's another one. So there's quite a few things that we have done internally out of pure necessity, because we needed to get ourselves trained. The training that we have done externally with other individuals has been more around advocacy, leadership, starting your own association. But I think there's room for those opportunities that potentially even the National Association can allocate some resources to have that be part of a webinar. I know we tried that before, but it does need to be more centered around individual needs of that community, because starting an association in California might look different than starting an association in upstate New York.
That's a great point. All right, so it is now time for our 7-minute break. We're going to take a quick 7-minute break. But before we do, we'd like you to reflect on the image on the screen, which illustrates your responses from your last community circle. Thank you for participating, and we'll be right back. If you are unable to join us in our community circles, we understand and appreciate your time, and please complete the survey before you leave here today. And when the 7 minutes is over, please turn your cameras back on so you know we know you have rejoined us. Breakout rooms are closed. Awesome. Well, I hope you guys had an amazing time in your community circles. I was able to drop into a few of them and hear bits and pieces of your conversation. That was just so moving. And it was just such an honor to be a part of that listening session. And we would like to extend our gratitude to each one of you who has joined us today. We hope that you leave here feeling empowered and informed on the CHW profession, and will make strides of action in areas of improvement. We also hope to see you back on October 27th for our grand finale of these installments of the data findings in action presented by our amazing Johnson & Johnson leaders. You are all in my thoughts and prayers. Stay safe and be well. Please take our action survey at the end of this session, and Allison will drop that in shortly. Aurora's already on it. There's the link to the survey right there, guys. And if you want, you can go ahead and pull out your camera phones and hold that over that QR code, and that will pull up the direct link to the survey as well. So whatever works easier for you. If you're on a phone, grabbing the link might be easier, but if you're on a desktop, scanning that barcode might be easier. And thank you all for answering that warm-up question. It was so beautiful to see your responses, and we will make a journal of all the pieces of advice that we should tell younger CHWs as we go through our leadership development programs.